Subham, and thank you, Professor Roth and Ramesh, and for giving me this opportunity to speak about an overview about the lung cancer burden in India. As you all know, this is the Globocan 2018. You see, the lung cancer is the commonest cancer today in both sexes for all ages, and also the mortality is the number one in case of lung cancer amongst all cancers. You see, coming back to India, again, this is the same Global Can 2018 report. Following the cancers of lip and oral cavity, in males, it is the second commonest cancer, and also it is the second commonest cancer death in case of males. Of course, in case of females, it is the fifth common cause of death amongst all cancers. And when we combine, then it is the third commonest cause of death because of all cancers in India. And this is again an interesting data of the global burden of disease study that had come in 2018. You see, in both sexes combined, this is the disability, the what we call the adjusted life years or the DALYs, that is the both sexes lung cancer was the third commonest cause, and in case of females it is the seventh, and you see the in case of males it is the number one DALYs, right, in India amongst all cancers. If you see, this is the changes in the incidence rates of different types of cancer that had occurred between 1990 and 2016. You see, in 1990, it was the sixth common cancer. In 2016, it is the fifth common cause of cancer. There is an increase of about 116% over these 25-26 years. So also, the crude incidence rate has increased by about 42%. And then again, this is an interesting observation about various states. This is the crude annual incidence rate of all cancers together in the state of India. That you can see that everything was green or yellow, but now in 2016, the all cancers, of course, is not for lung cancer. So accordingly, if it is the second most cancer, you can see that lung cancer also has changed accordingly. You see again this same data. If this is the data for 20 different cancers, for lung cancer, it was the first or second leading cause of cancer death in 19 states of India for males and 4 states for females. You can see this is either number one or number two cause of cancer death. Coming back to the history a little bit, in 1948, it was reported at that time that lung cancer is rare to extremely infrequent. But subsequently, the reports came from all parts of the country, from all over the country, and this I have just summarized about 40, 60, 50 different publications. I think what you have to note is that you see the adenocarcinoma, which was in earlier years. These are the reports of the earlier years that shows the adenocarcinoma was not that common. The common type was the squamous cell carcinoma. But if you see the subsequent reports after 2005, 2010, you can see in many places the adenocarcinoma has gone up, and that I'll tell you in subsequent slides. You see again the estimated number of lung cancers in the world and India, as you can see, it is expected that it will increase by about 25 to 26%. This is what I was telling you. This is the adenocarcinoma was constituting about 15% till about 85, 86. Then subsequent publications from India between 86 onwards that shows there is a increase in trend from 15% to 24%. Although squamous carcinoma was the commonest one, but however, please note that it was increasing. Then there was a comprehensive review of the lung cancer by that shows that tobacco use and air pollution were the leading risk factors, not only in India, in many parts of the country. And then another interesting observation, there is a great geographical diversity in this country. Reports from the eastern and northern parts of the country that shows adenocarcinoma is around 30%. Still, squamous cell carcinoma was the commonest. But from the western and southern part of the country, you can see the adenocarcinoma is becoming more and more common, about 40 to 42%. This again one of our own studies from PGI reported more than 1300 cases. You see, adenocarcinoma is now the commonest. It is almost same as that of squamous cell carcinoma, which was the reverse in earlier years. This again, this year, the report from All India Institute of Medical Sciences, you can see Anant Mohan and his team has reported. You see, adenocarcinoma is now the commonest cancer, and then the squamous cell carcinoma is the second one. And the same graph, it is the same thing is depicted in the graphic form. As you can see over the years, how adenocarcinoma is increasing in incidence. This is again another important observation about this is our own study that shows about most of our cases are in stage 3B or 4, and as you can see that. And then again the All India Institute data shows that about stage 3 and stage 4, there are about 95% of these cases they present at a very advanced stage. And in small cell carcinoma, it is again, you can see the extensive stage disease is in about 75% of the cases. So as I had told you, again, the tobacco use and air pollution are the leading risk factors for lung cancer. And again, this is a summary of the various relative risk of developing lung cancer. Smoking pattern is BD smoking is the commonest form here. The relative risk is again, the BD smoking is more riskier than the other types of smoker, and so also the passive smoking. And this is, I think, common picture. You all know the BD smoking in this country, and various, investigators, they have put the risk of lung cancer and BD smoking to as 3.38 to as high as 6.45 by different authors from this country. So the summarizing the risk factors for lung cancer, particularly as we see in Chandigarh, I think that is what also reflected in other parts. The smoking, then the smoking, passive smoking, and the BD smoking, cigarette smoking, hookah smoking, they are all responsible. And then this is about the passive smoking, the exposure during childhood, the spouse, workplace, and exposure in the vehicular. So these are some of the risk factors. They are responsible for lung cancer in this country. I think another interesting observation was the lung cancer in non-smoking Indian women. We tried to study the effect of biomass fuel, and you can see the use of biomass fuel. It is by univariate analysis and then multivariate analysis. The risk factor is higher. And again, remember, these are non-smoking females. So then in India, the various diagnostic methods, they are available now. I think they are all very well available everywhere, all centers, they're being done. Now coming to the part of lung cancer classification, how it has gone, we all know that it is now just, it is not enough to say it is lung cancer or it is squamous or adeno or like that, but we have to tell whether it is EGFR positive, ALK positive, MET positive, and what is the PDL1 level. So then we have to tell that, otherwise just telling lung cancer is not enough, and there is a mutation in the non-small cell lung cancer. There is a wide variation in geography all over the world. Then the Southeast Asian regions, it is the highest, and then the others in the more western countries, it is less common. Now let us see what is in India. The targetable mutations in India, this EGFR, these are the various studies from Mumbai, from PGI, from AIMS. So that shows about, these are, because there are many studies, not that these three centers are doing, I have put the maximum number of cases. So it is around 23 to 25% of cases. Then ALK again.
Sonal, ye Dr. Raman Rami.
Somebody is giving back. In the ALK one is around, report is around 2.4 to 11.5%. So roughly about 8% will be ALK positive. And then the RAS one is about 2 to 3% of these cases. The varies between 0.44 to 4.11%. So this is our PGI experience. About 2.8% of the cases done is their RAS1 positive. So you know, this is the summary of various drugs. They are available for various targeted drugs. Fortunately, they are all available, whether easily or not so easily. They are available in this country. And you know, this is the experience of crizotinib in ALK positive lung cancer cases, the median progression-free survival is about 11 months, and the median overall survival for the entire cohort about 34.2 months. This is the report by Malhotra et al., and this is the real-world experience from India. This is published in last year in Annals of oncology. So now coming to the PDL1, this is the era of the immuno-oncology or immunotherapy that has also progressed very well in lung cancer. You see the more than 50% the TPS tumor proportion score. So it is roughly more than 50%, which is we are more concerned about 20 to 25% of cases. Then what about India? About PDL1 testing done in lung cancer patients, that is our own experience of over 300 cases. You see roughly more than 50% is about 18%, and 1 to 50% is little more than that. And then we have got also some publications from different parts of the country, not very large number of cases, but there are various experience with immunotherapy. So this is again Gupta et al. They have reported about 8 cases. And then they say that 50% of cases show benefit, clinical benefit. So now what is the scope of this personalized therapy of lung cancer in India? If we calculate that way, the various mutations out of 100 patients of lung cancer, 40% of adeno, then 20-25% of AGFR, 8% ALK, 2% other rare mutations. So then roughly about 15 to 60% of cases they can be avoided. The toxic chemotherapy can be avoided, and if we add on to that, if PDL1 is added, another 20 to 25% will be getting or will be fit for immunotherapy. So roughly about 25 to 30% of cases of lung cancer will be treated with the targeted therapy, and obviously the remaining, those who are mutation negative, they can be afford the other therapy like chemotherapy. But are we ready to use these newer drugs? Obviously, we have to understand the cost, the availability, then all these issues are coming. You see, this is, I'm just giving one slide, the cost of tyrosine kinase inhibitors and other drugs in India. You see, some of these drugs, fortunately, because these are generic drugs, they are very cheap. They are available even much cheaper than that. But you see the other drugs like the third generation TKI, that osimertinib, and then the ALK drugs used for ALK positivity like crizotinib and ceritinib and the lorlatinib. They are available, they will be available, but again, they are not yet generic. So they come in thousands and lakhs. Of course, if you can negotiate the pharmas, they give various schemes, but still it is not affordable or feasible for many patients. Now, what about immunotherapy? Again, if you see the cost of immunotherapy, many company are not many actually, they are very branded drugs. So the companies may provide various discounts, which is not considered in this calculation. But if you see the one course as per the standard rate, it is crossing about 1 crore rupees for the year, right? If you see, many of these drugs are more than 1 crore. So obviously we have got the experience of using chemotherapy, various publications. Again, you can see the chemotherapy, these are only in months. You can see it is not very effective. This is our journey in PGI Chandigarh in early 70s, 80s, and I think I need not tell these things in presence of Professor Ruff, who is a veteran and has many more experience than me. And you see, then we started, and what I am just trying to share with you, and this I am sure this is the experience must be with the people when I started in the late 70s and 80s. Now the things are improving with better drugs. Earlier it used to be only in weeks, then we started in months, and then maybe just we have touched years. But again, you see, when we started using EGFR and ALK things, you can see for the EGFR outcome, we can see the overall survival now it is 2 years, and it varies between 372 to 893 days, and it may be more. Same thing with ALK, about 57 of the patients are surviving for 1 year, 34% for 2 years, and 12% 3-year survival, which is again a tremendous improvement. This is again a osimertinib experience reported from Tata Memorial. They can see the 75% of the patients, they become better. So again, ladies and gentlemen, we have to know the India, I should say, we do not know. You know, we are the world's second largest tobacco consuming nation. We have got so many 275 million tobacco users. There is a rising tobacco use. So the prevalence of tobacco use will be so high to see according to the population. So you see, I think what is something very interesting I came across that you see, this shows the global surveillance of trends in cancer survival. That is what called the Concord 3 study. This is an analysis of individual records, and you see they recorded 37.5 million patients. Those were diagnosed with cancer during the 15-year period. So they have 18 different cancers, and what they noted that in some countries survival has increased by up to 5%, that is of lung cancer. So there is some change. Earlier it used to be said that the 5-year survival 8%, 10%, 12%, 15%. But I think there is some improvement. This is what it shows. For India, this is shows very small graph that shows again in 2000, 2004 till 2014, there is an improvement, including many other countries. But we have just increased. We have not gone in comparison to the other graphs, as we can see. But what I'll say, when comparison with the 2000 to 2014, it has improved. Again, this is a just come in New England Journal of Medicine. This is the SEER data of USA. Please note here about the survival data between 2006 to 2013. You see when
Behera, you have just a minute.
yeah, just one more.
You have 2 minutes
yeah,
left, sir.
yeah, that is enough time for me, sir. You see, when in 2013, when these drugs, newer drugs started coming, the way that just the cases, the survive, this is the mortality rate. The mortality has come down. And the next slide that shows the 2-year survival rate in 2001 was about 26%, has risen to 35% in men, and in women from 35 to it has gone up to 44%. What I'm trying to say, it has shown a increase because of the newer drugs. So again, this is becoming something about medical oncology in India. As you know, we will have so many burden of new cancer in India per year, about 1.45 million. This will increase about 1.7 million. So, but unfortunately, there is not a lot of oncologists in this country. So our challenge is the delay in diagnosis, lack of sensitization of the primary care physicians, misdiagnosed as TB, diagnostic facilities, although available, they are not universally available. If there are treatment issues, treatment related issues, as I told you, the expertise, cost, and so on. So then obviously the practicing thoracic oncology in India, there are many problems. There is I think although the pulmonologist role is emerging, we have got many issues are coming up. I think that I will not tell you. The same thing I have already told you. So then now, there are many government schemes that are giving the financial help. We have got Ayushman Bharat, Prime Minister's National Relief Fund, then the Health Minister's Cancer Patient Relief Fund. And then this is we have got now the guidelines. And I think the most important thing for the cancer, we have the National Cancer Grid. And then I think one of the National Cancer Institute India at the Jhajar, where I think Dr. Roth and Pramesh are here. So we have got top cancer specialist institutes, we have got regional cancer centers, but I think still we have a long way to go. So ultimately we have to say that we have to take, when we are handling a case of lung cancer, we have to see the survival, quality of life, and the tumor response. Then maybe I think it is important to tell about lung cancer and COVID-19 when it is the era of COVID. There are many issues in the COVID, particularly this one slide I'll show you. I have just summarized 5 or 6 important studies. You see, when there is a COVID and lung cancer, 25% of them died, and then there is improvement about 13% and 52% recovered. So the lung cancer as such is not a risk factor unless there is associated COPD, AIDS, and other comorbidities like diabetes. But what it says, there are different guidelines, but basically it says that if it possible, provide them the care. As for many centers are doing that, specifically in PGI, our cancer centers are open. That is only one OPD that is open, and then but we have to take care of that the patient is not COVID patient, is not COVID positive, and so also the care provider is not getting the COVID. And I think one which was discussed during the previous session, if you see This left side, this X-ray that show this is the COVID chain, ground glassing. But this is one which is the immunotherapy induced pneumonitis. So if the patient, you should be very careful about that. And so just one word, this is about lung cancer screening. We know that this is the LDCT is the standard of care, the low dose CT. This is the lung cancer cases in comparison to chest radiography. So then the mortality is improved if you do screening with that. However, the cancer screening program, it should be sufficient epidemiological importance or information. There should be identifiable risk group and the high risk group. So there should be targeted population. There should be identifiable risk factor. There should be availability of technology, and technology should be sensitive. And there should be, even if you are diagnosing, the availability of further investigation and mitigation facilities and the cost effectiveness. And then obviously lung screening and smoking cessation should go hand in hand. What are the challenges of lung cancer screening in India, ladies and gentlemen? We don't have sufficient infrastructure. Add a lung cancer screening program. Then trained human resource, referral algorithm, the cost, psychological trauma due to overdiagnosis, pulmonary TB and other chest infections. You are picking up, the nodules. You remember the various infections, overdiagnosis in view of cutoff of lung nodule, assessment of high risk, then tobacco control and smoking cessation, and intervention availability that you should have surgeons, oncologists, radiotherapist, and the interventionist. So actually,
Dr. Behera, your time is over.
This is my last slide, madam. So these are the various strains. So I don't think in India we have yet identified any group. So with this, thank you very much.